Today we're going to be talking about borderline personality disorder. So, just as kind of a reminder, the last time that we did the stream, which was the first one that we did as part of like the mental health series, we talked about schizophrenia. And this time we're talking about borderline personality disorder. And again, if there's any type of disorder that you're interested in learning about, just let me know. I'd be more than happy to cover it. Otherwise, I'll just kind of pick one that I want to discuss and kind of go from there. But there is actually something else that I did want to talk about before. Sorry, I just turned on some music to have in the background. So there is something else that I wanted to talk about before I get into the stream. And the only reason I wanted to bring this up is because I guess since I started school, I get a lot of friends or people that I just know that I talk to that kind of ask me, what are you going to school for? Yada, yada, yada. They usually say, like, oh, when you're a forensic psychologist, So I kind of just want to cover this. Like, I don't expect anybody to know or understand what type of education goes into the mental health field, because that's really something that you would know if you're interested in that field yourself. So I kind of want to talk about the differences in Ash, thank you so much for that gifted sub to Tim. Keep subbed, yo. Yeah, keep subbed. So I kind of want to talk about some of the educational differences between various roles within the mental health field. So although yes, I'm studying forensic psychology, my program is at the master's level. So that doesn't mean that I'm going to be a forensic psychologist, right? So to have that title psychologist, you have to do a PhD or a PsyD. That's not where I'm headed, at least not at this time. I'm like almost dying at the master's level, so I don't know if I'll ever go to the PhD level. I guess I'll decide that in the future. So I just kind of want to throw that out there, that to have the psychologist title, you do have to have a doctoral level degree. So my studies are focused in the forensic field, so I get to learn a lot about kind of the intersection between psychology and the law, and therapy, and treating people that are in forensic settings, such as jails, things of that nature. So that's kind of the big difference. And then being like a clinical psychologist and a forensic psychologist, there's also some differences there. So forensic psychologists do deal a little bit more with like the law. They do a lot of assessments in jail settings, so they would be the ones that do like competency evaluations for the court. So there's a lot of differences there. I don't want to get too deep into it because there are so many like subfields within forensic psychology. But yeah, I just kind of wanted to explain that. So once I finish my studies and I have my license, I'm gonna be a master's level clinician. So I'm gonna be a licensed professional counselor. So that's kind of the main difference. Again, I wouldn't expect anybody to know that unless you're actually going into this field yourself. Just thought it would be something pretty good to cover, in case you were curious. But anywho, I just wanted to kind of talk about that. Do I get a cool hat? I do not get a cool hat, so I guess I should join a cult instead so that I can get a cool hat. But yeah, so now that we cover change fields, now that we've kind of covered that, I do want to also do a little trigger warning. So we are going to be discussing mental health disorders, and if you are in any type of crisis, just make sure, I did put the website on there, make sure that you contact 988. We are going to be talking about a little bit about suicidal ideation, so just take care of yourself. And another disclaimer that I do have to throw out there. So everything that I'm talking about is just basically from like an academic standpoint. So just bear in mind that I'm not yet a professional in the field. So I'm really just doing this as part of, teaching myself and also teaching you in the process. So that's the reason for these streams. So yeah, just bear in mind, I'm still a grad student, still haven't done my internship. So this is all coming from like my textbooks, things that I learned outside of that. Okay, so borderline personality disorder. This is part of the group of personality disorders, and there are several that are included in here. So there's also different clusters. Okay, so cluster A type personalities includes paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. So these personality disorders are kind of more like the personalities that come across as a little bit more odd or eccentric. Cluster B tends to be more dramatic, emotional, or erratic. So this is also where borderline personality disorder, or BPD, I'll just be saying BPD from now on. This is where BPD is as well. And it also includes antisocial personality disorder, histrionic, and narcissistic personality disorders. And then we have cluster C. So cluster C is more of like the anxious or the fearful type. So in this cluster, we have avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. So we have some other ones that are also included as part of personality disorders, even though they don't belong to a particular cluster. So there's personality change due to another medical condition. So this would be like if somebody gets in an accident and they experience like a frontal lobe lesion, and they have a personality change due to that. So it would kind of fall under that category. There's an other specified or unspecified. So there's this criteria that's listed under those, but again, we'll be covering BPD, so I won't go into detail as far as those are concerned. Okay, and then now getting into BPD and the criteria. So, and I'll kind of like break down and explain what each one means. So the criteria is basically that there's a pervasive pattern of instability with relationships, self-image, impulsivity, and this also usually begins in early adulthood. So I'm going to be referencing the DSM criteria, which last time I showed you guys that big giant book. So I'll be referencing what's in the DSM, but I'm also going to be referencing Dr. K, which if you've been around here for a while, you've heard me mention him. So he's a psychiatrist that also streams on Twitch, and he talks about all of these things. He talks about a wide variety of stuff. So he does have a really, really good video on BPD, and he kind of breaks it down, and he has such a beautiful way of explaining things. So I'll be referencing him a lot, and it helped me kind of understand it a little bit better from more of an empathetic perspective, because just to be a little transparent, I felt like when I learned it in the course where I was taking it, I felt like that was lacking. It was lacking some sort of empathy, right? So Dr. K kind of provided that in his video. And so even as he says, this is one of the disorders that are pretty stigmatized and very misunderstood, which coincidentally, I feel like schizophrenia is one of the other disorders that's heavily stigmatized, and we covered that last time. So in order for somebody to meet criteria, they do have to meet 5 of the following criteria. So the first one is frantic efforts to avoid real or imagined abandonment. So this doesn't include suicidal ideation or tendencies or like self-mutilation. But what this means is that the person is very sensitive to any like environmental changes, anything around them that's constantly changing. So if they feel like they're being abandoned, they directly assume that they're bad, so they frantically try to avoid that from happening. They don't want to be abandoned. So I'll give you an example. In a previous course I watched, because we watch a lot of like example therapy videos, so I watched a therapy session with a client who had BPD. And when the therapist was ready to end the session, the client started doing everything that they could to extend the session, to make it go longer, to make it go past the hour that they were meeting. So they started becoming very agitated, but the therapist, set very clear boundaries and had to end the session. So that's just kind of a very simple example, but even the discomfort in that, that one session coming to an end is a lot. It's very intensified. It's very painful. The second criteria is a pattern of unstable and intense interpersonal relationships characterized by extremes of idealization and devaluation. So what this means is that the interpersonal relationships, so whether it's romantic, friendships, family, they're very, very intense for people who have BPD. So the intensity also happens very, very quickly. So as Dr. K explains, it's kind of like a high octane relationship. So they idealize relationships very, very early on. So it's kind of like a very quick attachment, and everything is like moves very fast. It's very intense. So from like the first or second time that they're meeting, it gets serious very quickly. And then, you want to spend so much time together and be together all day, every day. And usually people with BPD can empathize with other people, but there's also that expectation that the other person will be there for them in return every single time that they need them. So things can turn pretty quickly, and they start to devalue that person. They feel disillusioned, or they feel, again, that abandonment. They feel like the person is not there for them, or they don't, the other person isn't doing enough for them. So the third criteria is identity disturbance. So this is markedly and persistently unstable self-image or sense of self. So this presents itself as like a sudden change from needing someone, to, as the DSM says, like a righteous avenger of past mistreatment. So one thing to know is that people with BPD have a high negative self-image. They feel that they're bad or they're evil, but they also feel invisible, like they don't exist at all. And this is like pretty, again, I want to reiterate that this is like really intense for people who have BPD. So they feel like they can't have any kind of meaningful relationships. They typically perform pretty badly both in work and in school, so they can, they have a really difficult time keeping up with that. So that's kind of what identity disturbance is. The next one is there's impulsivity in at least 2 areas that are self-damaging. So examples of this are like impulsivity in spending, in sexual activity, substance abuse, reckless driving, binge eating. And this criteria doesn't include suicidal or self-mutilating behavior. So it would just be, at least 2 areas from the other categories that I mentioned. And cutting or burning are pretty common, and they can happen if the person is experiencing dissociative symptoms, and they're done because they feel some sort of relief, or, hurting themselves is kind of like reaffirmation that they're able to actually feel something. So that's usually why those behaviors happen. The next category, this is where we include recurrent suicidal behavior, gestures, threats, or self-mutilation. So it's its own separate category because it's just not included in the other ones. It's its own separate category. So again, when the person starts to feel abandoned, there's that intensity, and they like we kind of mentioned before, you know, they're very frantic. They want to make sure that they stop that from happening. And also there's also that negative self-image. So that's why there's a lot of self-mutilation, there's cutting, there's suicidal behavior with this population. Next category is affective instability due to marked reactivity of mood. So this would be like intense dysphoria, irritability, or anxiety lasting a few hours and rarely more than a few days. So the person can feel dysphoria, which is pretty much like a very intense unhappiness or dissatisfaction. But that is interrupted by feelings of like anger, panic, and despair. And it's very rare that these populations feel satisfied or happy. The next category is just the chronic feelings of emptiness, which emptiness or, you know, feeling alone. So, and this is chronic, which means that they're experiencing this very, very heavily in their lives. Next category is inappropriate intense anger or difficulty controlling anger. So this would be them being very temperamental, just constantly angry, recurrent physical fights, anything like that. And then the last one is transient stress-related paranoid ideation or severe dissociative symptoms. So this means that it doesn't happen enough for it to be a sign of another diagnosis. But again, like, I just want to reiterate that this condition is very, very severe for people with this disorder. I'm constantly angry in Overwatch. That's because you jump into the whole team by yourself. That's why. Just kidding. Okay, so now we kind of move on to some causes. So what causes BPD? So some things to know about people with BPD is that they sometimes experience death by suicide. So again, we talked about how just recurrent suicidal ideation, self-mutilation, that's typically present with this population. So they do experience death by suicide, especially if they also have a substance use disorder or if they're diagnosed with depressive disorders as well. That's also another thing to know, is that with this condition, a lot of times there is overlap and people they may, you know, have suffer from more than one disorder at the same time. But even though there is death by suicide in this population, accidents or illness happen twice as often as death by suicide. So accidents or illness are far more common with them. They can also experience self-inflicted physical impairment from some behaviors, such as failed suicide attempts. So they can have, you know, permanent damage from that if they survive the attempt. So it's also more common for the population to have experienced some type of abuse, neglect, hostility, or parental loss very early in their childhood. And that doesn't mean that every single person has experienced that, but it is very, very common to find a pattern of that with people who are diagnosed with BPD. There have also been some people that have been as young as 12 to 13 years old who have met the full criteria for the disorder. So it doesn't only happen in adulthood. There's also no exact numbers or percentages that tell us how many adults who enter into treatment had an early onset of BPD. So it's not really clear how many people who actually seek treatment, you know, met the criteria when they were younger. But it's pretty possible that they could have met criteria when they were younger than when they were diagnosed. So I hope that makes sense. And another thing I want to mention is that studies are showing that there are pretty stable remissions for people with BPD. So once they actually do go into treatment, there is success that comes from that. So Dr. K mentions that in his video, but it's also mentioned in the DSM as well, actually, that there's a pretty good chance of remission for people who go into treatment. So you see less impulsivity, and that's kind of what diminishes the most rapidly through treatment. There's also a little bit of a genetic component, because it's about 5 times more likely for people to be diagnosed with BPD who also have first-degree biological relatives that have been diagnosed. And there's also a higher risk of substance use disorders, anxiety disorders, antisocial personality disorder, and depressive disorders as well. So that's kind of what I mentioned a little bit ago, is that it is very common for somebody who has BPD to have at least one other condition. So there's a lot of overlap there, and that's why there's also kind of like a genetic component to that as well. So another thing that was very interesting is that it seems like women are more likely to be diagnosed with BPD, but it's also possible that women are the ones that tend to seek help or treatment more often than men do, because there have been samples that have been taken from the community that shows that there's not much of a difference. So it could just be that treatment seeking is more often found in women than it is in men. So, anybody have any questions so far about the criteria or some of the things that cause BPD before I kind of go into treatment? And I hope that made sense. So if there's something that didn't make sense, or if I'm moving too rapidly, let me know. Pretty straightforward. Oh, thank you for explaining it well. Thank you so much. Yeah, and it does sound straightforward, but honestly, like, it is kind of more difficult just because there's so much overlap in personality disorders and with this one as well. So I wanted to keep it, strictly focused on like somebody only has BPD, right? Because it's a little bit easier to understand. So as far as treatments, I'm really only going to cover or focus on one type of treatment. Hey Tara, how's it going? Happy Sunday. So I'm just going to cover one type of treatment for BPD, which is dialectical behavior therapy. So I'm going to call it DBT. I know it's like all these acronyms. So I'm going to call it DBT. And I do want to clarify that it's not the only type of therapy that's going to be helping somebody who's been diagnosed with BPD, but that's kind of more of a conversation that would happen with a therapist when somebody seeks treatment. You would have that conversation to determine what is your best therapy. But the reason I'm going to be talking about DBT is because this was designed specifically for BPD. So I'll kind of go into the history of that. But I do also want to say that as far as medications are concerned, they could potentially be part of treatment if the person has other conditions as well. So if they're diagnosed with like depression or anxiety, sometimes those are treated with medication. And depending on what what kind of symptoms a person is having or how distressed they are, there could be medication involved. But generally, psychotherapy is what's used for people with BPD. So I mentioned dialectical behavior therapy, or DBT. This is an intervention that was developed by Marsha Linehan in the 1970s. So her story is very interesting because she developed the very therapy that helped her. So she was struggling and she had to leave her job for some time. So she went to a monastery and she learned the basic concept of what she calls radically accepting everything and then letting go of the things that you want. So what she describes, and this video is also actually posted as part of the resources if you want to check it out. It's not a very long video, but she explains all this herself. So she describes it in a way that that you kind of move moment to moment and you let go of anything that you want. So you're radically accepting your current reality, what is. She completely immersed herself in this experience as a student at the monastery, and she stayed there for about 2 months. So DBT was developed to treat BPD, and I do believe that she was diagnosed with BPD. I don't know if she was diagnosed or it was like a self-diagnosis type of thing. Honestly, I don't know, but I'm pretty sure that she has BPD or had BPD. So the foundation of DBT is that it's focused on the perspective of reality and experience. So in other words, what this means is that the world is just constantly changing, constantly shifting, and people are always transitioning. So things are changing all the time, right? Even for everybody, they change for everybody. Even if you have like a pretty stable life, I mean, things always happen, things come up, things change all the time. So that it's kind of rooted in that. And a person's knowledge base and the way that they cope comes from their life experiences, which can also lead to dysfunctional relationships or unhealthy coping mechanisms. So just to kind of go back to some of the causes for BPD, we talked about how a lot of times it's very common for people with BPD to have experienced, some form of abuse, neglect, anything like that. So when you think about all of those experiences, that doesn't really teach people how to find healthy ways to cope with life and cope with stress and changes. So that's kind of what she means about somebody's knowledge base and their experiences is how people learn to deal with that stress, and that's why it's dysfunctional, and it's heavily dysfunctional in BPD. So what this intervention does is it helps people with BPD because therapy such as cognitive behavioral therapy that we kind of briefly talked about the last time, or CBT, is very common, and it helps clients kind of focus on modifying how they think, feel, and behave, but it doesn't really address the very intense emotions that BPD clients are experiencing. Because again, we talked about them having like high octane relationships, right? Everything is very, very intense. The intensity level is like up here. So something like CBT doesn't address those factors, which is why it's not as helpful for somebody with DBT, because they end up feeling like they're inadequate or they're just being criticized when they're in therapy. But it's also one thing to know is that, and I know I mentioned this last time, so if you were here for the last one, you may have heard me say that there's a lot of like branches that came off of CBT, because it's very, very common, but there's a lot of different types of therapy. So DBT is kind of like a branch off of that. It's kind of like a new wave of therapy. So it's kind of a fusion of CBT and as well as like acceptance, which comes from Eastern practices. It's the best way to describe it is it's a very supportive type of therapy. So it also includes things such as doing homework assignments, having some kind of role play in therapy, learning techniques for self-soothing, and learning to tolerate frustrations. There's also some additional things such as meditation, again, kind of that Eastern practice, coming from that Eastern practice. So things like meditation, regulated breathing, and relaxation, which can help people be more self-aware and attentive to everything that's going on around them. So I'll kind of give you like a very basic rundown of the stages of DBT, which will kind of explain kind of how it's oh my gosh, what's that word? How it's structured. So the first stage is regaining some form of control And this is meant to target several different areas in somebody's life. So the first one is reducing and eliminating life-threatening behaviors, which include suicide attempts, suicidal thinking, and self-harm. So this is like the priority when it comes to DBT, which again is another reason why it's very helpful for people with BPD. I mean, outside of the fact that it was developed for BPD, but it prioritizes that because that's definitely the one thing that you want to address first if there is some kind of suicidal ideation or behavior. The second thing that it will target is being able to reduce or eliminate any behavior that's getting in the way of therapy. Things like, not attending sessions regularly or not completing any homework assignments. The third is decreasing behavior that interferes with quality of life. So we're talking about things like depression, any kind of phobias, eating disorders, not really having any friends, not being able to budget, ignoring medical problems, and it also works to increase behaviors that are going to help quality of life. So attending school or work regularly, establishing some friendships or working on maintaining friendships, learning how to budget, and so on and so on. The fourth thing that it targets is learning new skills, such as increasing concentration, creating new friendships, being able to understand emotions, and being able to endure pain without any kind of self-harm or self-destructive behavior. So kind of more like self-regulation. So that was all part of the first stage, right? The first stage of DBT treatment. The second stage is being able to experience emotions fully without shutting down or letting emotions become unmanageable. So as we kind of mentioned when we talked about the criteria, this is something that people with BPD really struggle with. They don't necessarily have those skills to be able to learn how to manage their emotions. So this is helping them be able to experience them fully and understand them without just shutting down or without without being unmanageable. The third one is building an ordinary life and learning to solve ordinary problems. So some of the things that are, that are considered ordinary problems would be like, just common everyday problems that we all experience. Something doesn't go our way, you get some kind of bad news. I don't know, your tire popped or something. You know what I mean? Just like everyday things, like learning how to solve those ordinary problems. And then the very last stage is moving from incompleteness to completeness or connection. So this stage is kind of like a continuation of the third stage, but it was included for people who still feel incomplete or people who couldn't exactly see as much relief from the third stage. So it just sort of continues, for people who are having a difficult time with that. So that's kind of like, I know it seemed like a lot, but that is kind of like a simple breakdown of what you might expect to see in DBT treatment. It seemed like a lot, so I hope you're still bearing with me. But that's, I mean, like I said, it's not the only type of therapy that somebody in BPD might see, but because I chose to focus on it because this was developed specifically for BPD, so it's very good. It's a very good form of therapy. So some concluding statements that I do want to make about BPD is that the process of change for a client who's been diagnosed can be pretty slow, and treatment can be pretty lengthy. So what might make some of that more complex is how often people have other disorders. So, we mentioned that before too, how they could have substance use disorders, depressive disorders, anxiety. That's kind of what might make things more difficult because, it might be in their best interest to use medication alongside therapy. So there's a lot of different factors as to why it might take a little bit longer. You know, another thing is that it doesn't help that this is one of the disorders that's also more stigmatized. So that also prevents a lot of people from seeking help and seeking treatment. So I think, you know, we have a lot of work to go when it comes to that, and not stigmatizing these disorders. So if you're interested, again, I highly recommend watching Dr. K's video. And I actually, here, I have a link to it if you want to check it out. It's about a 30-minute video. So if you want to gain a better understanding, you know, from a professional with clinical experience, I will not take it personally because I know I'm only a student. But no, he's a wonderful resource. I love how he explains things. But yeah, what he essentially says is that people with BPD experience such emotional pain that it's almost like their nerves are on fire. So it's very painful. Not to say that other people don't experience pain when it comes to dealing with their emotions, but it's just a lot more intense for people who have BPD, you know, from their subjective experiences. And they're able to recognize that their life just feels harder than other people. So again, it's a 30-minute video, but if you're interested in these topics, highly recommend it. Yeah, I agree with Ash. He is amazing. I love Dr. K. I love how he explains things. He really simplifies it to where, like, you don't have to have a mental health background to understand what he's saying. So that has helped me a lot in my studies. Because, you know, even though I have that background because it's what I'm learning, I still love being able to listen to him talk because I'm like, okay, I get it. You know, he's not throwing out all these fancy words. He actually explains what it means. But yeah, that's basically what borderline personality disorder is. You know, again, like I said, one of the most stigmatized ones. So I think part of it could be that people who have relationships with people with BPD kind of struggle because it is, you know, again, we said it's that intensity. A lot of people may not have patience for that. And I'm not saying that somebody with BPD is bad or anything. They feel bad about themselves, you know, but that's kind of what makes it a little bit more difficult is a lot of times people don't want to deal with stuff, right? So I think, you know, we have some work to do in as far as, you know, destigmatizing not only mental health, but destigmatizing different disorders as well. So again, this is part of Cluster B personality disorders. And yeah, if you guys want me to cover a specific disorder, let me know. I am more than happy to. If not, then I'll just kind of go through the DSM and pick one myself, and then we'll go from there. But if you're interested in rewatching this, I will be saving the video and uploading it to Discord. I'm uploading them to my YouTube channel, but I don't have them public, so they're unlisted. So if you want to rewatch, or if you want to see the resources that I used, both of those will be posted in the Discord under my mental health streams channel. So thanks again for being here for the mental health portion of our stream. So until next time.